Okay, good afternoon, everyone. My name is James Daniel, and this is the monthly EHR Vendor and Public Health webinar. And today's topic is the 2019 novel coronavirus, or COVID-19, and health information technology sharing session. I can move on to the disclaimer. So these calls are for discussion and outreach to the health information technology community only, and should not be treated as attempts to disseminate scientific or health IT knowledge. The findings and conclusions in this presentation are those of the presenters and do not necessarily represent an official position of the U.S. Department of Health and Human Services, and also a reminder that this webinar is being recorded. Next slide. So we have allocated time after the presentation for Q&A, at which time you may submit your questions, preferably via the Q&A or the comments section in the webinar tool, or you can feel free to ask those along the way as well, and we will get to those at the end of the presentation. Next slide. So today, what we're going to start with is just an overview of what we have done in the past for sharing some of our information around Zika and Ebola. And I will be helping with that, as well as Dan Chaput from the HHS Office of the Chief Tech, from the Office of the National Coordinator for Health IT. And after then we give the overview of what we've done in the past for Zika and Ebola, we're going to hear a little bit from Stephanie Holscher, Susan McBride, and Dwayne Holscher about what they've done for using some of the lessons learned from Ebola and Zika, and how they've started to incorporate that into their workflow for COVID-19. And then we want to leave plenty of time for a Q&A discussion piece as well. You know, we do want to hear from your group, from you guys, you know, after we've talked about this, what you might need from us, you know, in the same vein as what we did for Zika and Ebola, in order to implement anything in your workflows for COVID-19. So we definitely do want to hear from the community about what you need from us. Next slide.
Hey Jim, as we advance forward, can you speak up just a little bit?
Yeah,
we've had a request
I wonder if my
about
mic is
volume.
Going. Is that better?
I think a little bit, yeah.
Okay, I wonder if my mic is in a different place. Okay, I'll just try to talk louder, so no matter where my mic is.
Yeah, that works better.
Okay, great.
Yep.
So, you know, just a reminder of what we've done in the past. We have, you know, always been building upon our lessons learned from previous responses, such as Zika and Ebola. And we have always tried to reach out to the health IT developer community to see what kind of information they need to help translate clinical guidance from the CDC into guidance that is easier for health IT developers to understand. We've done some algorithm development. We've created, helped create some vocabulary sets, some standard vocabularies and some standard order sets, so that it's easier to incorporate all of those into your products. And also some of the things we've heard in the past is how helpful it is to have static websites with the most recent information. So just as kind of reminder, and we'll go into a little bit more detail on what we have done in the past around these efforts, but these are the kinds of things that we've helped bring together for the health IT developer community to make it easier for you to implement these recommendations into your product. So again, that's what we want to hear today after the presentations is, what do you need from us now? Are there things that we need to start producing for you to make it easier to implement these recommendations into your workflow? So Dan's going to go into a little bit more detail now about things we've done in the past, and then we'll hear from the Texas team about things that they've done specifically around COVID-19. Dan, go ahead.
Hi, Dan Chaput from ONC. And David, let me know if you need more volume. So early on, the guidance coming from the clinical teams was dense and early on in the Zika. And it was difficult for developers, the IT developer community, to take those and actually turn them into something that they could operationalize in their products. So it was unclear as to exactly what the flow was, because it was dense and it didn't have any sort of a normal structure that one might see in a flow chart. We did some very rudimentary work on the next slide, which took that same sort of information and just used the couple of standard flowchart symbols, such as the triangle for or the diamond for the decision, and the rectangles for processes, and tried to come up with something clearer, because we found that in the previous diagram there were boxes, which are usually processes, and they mixed decisions and process, so it was somewhat confusing for the developers. So we came up with this rather routine, rudimentary way of doing it. You'll see some labels here, the D1 and the P2. Those refer to some other documents that we had behind the scenes, which have all the detail in it. We didn't try to come up with a one-pager that would answer every question that someone could just sit and go through, but we tried to come up with a set of documents that was meaningful to either the systems analysts or the developers who are going to take this and implement the algorithm in an electronic health record. We did not want to dictate workflow, but we wanted to present the pieces that could be used either with prompts to the provider or with clinical decision support. It could be implemented any way the electronic health record needed, but we just wanted to make it clearer so that hopefully there would be a more consistent way of the electronic health records implementing the logic. So this was our algorithm. Ours are looking cleaner now with our newer ones. On the next page, so behind it, the sorts of things that we included in the documents that were behind those were, informations on transmission, prevention advice, the questions on sexual transmission. So we provided all the links to the extant documents that there were at the time. And on the next slide, we also provided information with all the vocabulary sets. So if anyone wanted to actually implement these processes using clinical decision support, they had all of the value sets that were related to the charts that you saw on the two prior pages. So we worked closely with the vocabulary teams. We worked with AMA on getting all the codes approved and approval to use the codes in our documents. So there was a whole bunch of work that happened behind the scenes in order to get this information together and push it out. So there are projects going on in translating clinical guidelines and doing that. And we found ourselves that, biology has caught up with us once again, and we are confronted with COVID-19 on the next slide. And here's a list of the links of all of them from CDC on guidelines and guidance for COVID-19. Right now, the algorithm for do I isolate a patient is really rather simple compared to the very complex Zika lab testing workflow that you saw earlier. So right now it's the much simpler algorithm. So we haven't gone and flow charted it out because it's very straightforward. But here's the background information. We did get reports from anecdotally that, a number of vendors had done different things. And we approached the EHRA, the Electronic Health Records Association, asked them to pull together their vendors, and had a brief call with ONC and the vendors to discuss what they were doing. And all the vendors are doing something very similar. And we also asked our partners at Texas Tech to present on where they were going, what they were doing, especially in relationship to Zika, because we worked very closely with them on Zika in the past. So I believe that's my last slide. Next slide, please. Oh, just more information. Next slide. And so I will turn it over to our friends at Texas Tech and let them continue. And I haven't gotten the question yet, but I am sure that there will that these slides will be published in the near future. So we'll just put that question off for the time being. So folks from Texas Tech.
Yes, this is Susan McBride, and I'm going to launch the discussion and our overview of what we've done to address COVID-19 or coronavirus. And just say that, you know, these resources that we get and these sessions that we did surrounding Ebola and Zika were incredibly helpful to our organization. And what we found is that these technical documents, particularly with Zika, as you look at them, they're very complicated often. They're critical in terms of the complexity of understanding exactly what we need to do in the clinical setting. And so we just want to acknowledge the importance of these types of collaborative, coordinated events with our federal agencies that really stay on top of volatile situations such as Ebola and Zika. And say that then what, of course, has to happen is we've got to map it to our clinical environments. And, of course, the vendors have to take it within each of the certified products. And we've just seen such immediate success stories around COVID-19 with our vendors rolling out things very rapidly, but also the clinical setting able to take our lessons learned from Ebola and Zika, use those lessons learned and roll out a rapid response to COVID-19 now. And so what we're going to do is share our success story. But before we do, I think we just want to acknowledge the fact that, you know, so often we hear about these certified products under high tech and now promoting interoperability program that, you know, they're creating distress and burden of documentation. And often when we put things in place, like our infectious disease modules, we can actually increase that documentation burden. So to really think through our clinical workflow and how to design these things with quality improvement methods, good evaluation strategies that have our clinicians and our other stakeholders involved, and governance teams that help us really deploy this kind of thing rapidly, but also working for clinicians and not against them. And that's what we tried to do with our approach to all of this, our lessons learned with Ebola, then Zika. And so what you're going to hear about today is a rapid deployment model for infectious disease. We had 2 doctoral students that took this on as their doctoral project with amazing work that was actually funded through CDC grants for nursing informaticists doctoral projects. So they both were awarded CDC grants. It happens to be an amazing husband-wife team, Dr. Stefan Helscher and Dwayne Helscher. And we're going to share their approach to how they built this with an interprofessional team. And so at this point, I'm going to turn it over to Steph and Dwayne to talk about the project, just really emphasizing workflow, how critical it is to redesigning workflow into making your clinical decision support work for you within these certified projects. And so, Steph, you want to share how it's been approached at our Health Science Center and University Medical Center?
Yes, thank you, Dr. McBride. Next slide, please. So my name is Dr. Steph Helscher, and together with Dr. Dwayne Helscher, and yes, as Dr. McBride said, we are actually married and work for 2 separate institutions, but together as a joint venture on this particular project. We are the boots on the ground informaticists that proposed and designed, implemented several infectious disease CDS systems over the years. This process is much more than we'll have time to discuss today from A to Z. But of course, if you have any questions, our contact information is on the latter slide. Let us know if you have any other questions. Back one, please. Thank you. So now Jim and David previously spoke to some of the history, and that's also the start of our story. Starting with the Dallas encounter. Now, Dallas wasn't the only ones that was caught unawares when Ebola hit Texas in the United States geographically is quite large, but we do consider Dallas-Fort Worth right down the street from us. And we weren't ready. I'm not sure that anybody was. I would really categorize Ebola, our build in the system when it did hit, as a bit of a knee-jerk reaction. We wanted something in there and we wanted it in there now. We're very fortunate at our location to have the ability to do some custom build in our EHR system apart from our vendor. So we had an alert turned on very quickly, but the maintenance aftermath wasn't really standardized or policed and not addressed as well as it should have been until Dr. Helsher and myself took over the project with the reemergence of Zika a couple years later. So with Zika, we as clinicians and informaticists really had to change our way of thinking when it came to infectious disease clinical decision support. We had to make it a point to take ownership of this process, develop a maintenance cycle, and have policies in place really. And also with that, on top of it, develop a way to note if the not if, but when virus X is going to be coming, and is it here, and what do we need to do to turn something on very quickly. So we developed our rapid deployment model, and with the guidance of our clinical experts, colleagues, a great partnership with the CDC, the OMC, HHS, moved to develop better ways to really digitalize these evidence-based guidelines quickly while still maintaining usability for all the applicable clinicians that it interacts with. And as Dr. McBride said, we don't want to add any to documentation burden, and not just physicians, but nurses as well, because they're really the crux of the process in most of these instances. So with coronavirus, we were really given our real world test of our model. We had a working version of it, good enough for deployment, up and running within a couple hours of our decision to development. And of course, we did a little bit of tweaking as the week went on, but really we had something good to go the same day. It's already caught appropriate cases for further evaluation, and with feedback from our emergency center medical director here locally, where just about we anticipate things will be coming through, but we of course work with our ambulatory and inpatient settings as well. So far it's working as designed, and we couldn't be more thrilled with that. It is worth noting, and I think Dr. McBride mentioned this, that with all the efforts and emphasis since Ebola and Zika nationwide, even globally, on more timely processes in the electronic health record for detection of pandemic potential diseases, amongst others, this is really the fastest vendor turnaround time I've personally noted. So kudos to the vendors. I mean, that's amazing accomplishment to get everything done that fast. Next slide, please. So Dwayne's going to speak a little bit more about workflow and algorithm development here in a minute, but we do have an actual governance process in place. So when we're not in emergency change control mode for issues like coronavirus, COVID-19, we do actually have a way to go and get more feedback, better buy-in, better approval systems and documentation per our policies when we have a little bit more time to flex. So integration of the institution's infection prevention and control departments was new with Zika, and we learned a big lesson on that to keep them engaged. They do this for a living. They got the one job, is to take care of infection prevention and control in the institutions. And they have flourished with coronavirus, much more engaged. They have stuff more at their fingertips. They're getting special alerts and messages when things fire, and they love it. And they're very communicative back to us with feedback of things that can be tweaked, made better, or gotten rid of. Our acute care, they're included pretty much in our primary focus group, and the bigger non-maintenance decisions are made, such as like if we want a new alert, say for MERS, which was our first seasonal alert that we turned on a year and a half ago, and it follows the time of the Hajj every year, the Hajj pilgrimage with Saudi Arabia. So that's the kind of things you can come up with when you get this interdisciplinary, interprofessional group together and you work together. Our acute care and ambulatory nursing informatics committees were very integral. These committees provide a voice for bedside nursing because they're our primary data entry participants with our particular workflow. And they are tremendous sources of feedback for any tweaking that might be needed to make the system tighter and more usable for them, as well as our providers, our physicians and nurse practitioners and such. The data they enter can make or break the entire system. So it's vitally important to keep them educated and engaged and feel like they're part of the process. The rest on here is basic outline for our emergency change control process, such as what we really use to get the coronavirus CDS turned on so quickly, as well as our more traditional governance approval process that I spoke about previously. So I'm going to go ahead and turn this over to Dr. Dwayne Helsher now to discuss algorithm development, workflow, and clinical decision support design and build. Next slide, please.
All right, thank you, Dr. Steph Helsher. As Steph said, my name is Dwayne Helsher, and I'm going to discuss some of our basically how we did this. What you're looking at right now is the top portion of a larger algorithm. When we were looking at how we were going to tackle this project, we started looking at the commonalities. And so with the governance committee that Steph mentioned before, we identified 4 key areas for most of them. Now there are one-offs such as Zika. You know, we had to incorporate the partner travel and issues such as that for that module. But for most of the rest of them, it involved things like exposure. Do you know you've been exposed? The symptomology, travel, both location and travel time frame. Most of these are within about 2 weeks, 3 weeks, and that's when the infectious period lasts or can be transmitted. We also looked at these criteria based on the CDC, WHO, IDSA guidelines, and that's not all. We do a couple other ones. Since we're in Texas, we keep an eye on the state health services website also. And we looked at their guidelines based on symptomology, hotspots, and their travel time frame also. Again, we don't just, as Steph mentioned, we don't just make changes. We make sure we're involving our governance committee, and we even are now involving more of our infection prevention department also. But if you look at this, if we look at the slide right now, basically for coronavirus, there was, were you exposed? Since it's growing, we know there's going to be more exposures coming up. We know that the CDC and the other folks are working on a vaccine, so that's a future state. We have incorporated vaccines for measles, where it won't fire. If they've been vaccinated, it will not fire or alert the provider. And so the next step is, do they have any kind of symptoms? If the answer is no, then we stop. And then the last one is foreign travel, and exposure and foreign travel do not have to necessarily be linked, meaning that they can be exposed and have symptoms, and that would place an alert, or they could have symptoms and have, especially foreign travel to China, for example, then it would fire the alert to the provider. So that's to start the process. That's how we set ours up. And so if none of this qualifies, such as there's some symptoms but they travel somewhere else, it'll proceed on down to a generic travel alert. We wanted to incorporate that as we call it a catch-all, where it allows critical thinking from the provider's point of view on, you know, this patient's traveled, there might be something going on. Is there something else that I need to do? So next slide, please. So basically, the algorithm feeds from the nursing documentation. Nursing documentation happens at all entry points like where the patient's admitted. We do potentially, the intake documentation is not addressed whenever they're getting into things like laboratory and radiology. So we do still risk missing a few of them. And as I mentioned before, if the algorithm does not qualify for the corona and it does not qualify for any of the other ones, then we proceed to the generic or the generic catch-all alert. We also, so some of our future states that we've been talking about and looking at, I noticed somebody asked about leveraging FHIR. Yes, we are actually looking at that. We want to investigate that to see if we need to, how we can get that information in. We also have to make sure that our information is mapped the way it needs to be, so that it can push or pull to get the information from whatever repository that we're using. We also continually talk about automated orders such as isolation carts, consultation orders, diagnostic testing, x-rays, lab, etc. And we as an institution decided not to do that because we want the providers to think about, why they're ordering. There's a cost for all of this. Next slide, please. And so this is the entire algorithm. When we were looking at coronavirus, our infection prevention is actually the ones that reached out to us, or one of the first departments to reach out to us. And so we started looking at, how do we get this into the system? Well, we looked at our MERS algorithm, and it was one of the ones that was most closely related to the coronavirus. And it was also developed from our rapid deployment model that we used. Tuberculosis as a case study for that. Like I said earlier, we do follow the CDC guidelines. Right now for coronavirus, they're interim, but they're stable. They haven't changed in probably 3 weeks or so, maybe a little bit longer. One of the biggest things that we did is we prioritized the rules, and so are our modules. So, for example, if Ebola shows up, that one's going to fire probably, if they meet the criteria, it'll fire every time. But if that one fires, then, or that one fires, and depending on the rest of them, what they qualify for. The coronavirus, for example, if the coronavirus fires, then the measles will not fire, for example. We talked to our infectious disease experts and our governance committee, and we put this prioritization, the prioritization model in place so that we were not over alerting the providers and keeping the quadruple aim in mind with this. And they also wanted to go one step further, so our pop-ups or our alerts to the providers will only fire once per visit per end user, and that's when they enter the chart. If all the documentation's there, then it'll pop up the alert. Ours uses Boolean logic, and with if-then logic, it can go pretty much across any kind of EHR platform. You just need to make it fit your workflow. One other thing that we did before I get off this slide, we put dynamic phone numbers in there based on patient location. So if the alert shows up and the provider has any kind of questions, we put a phone number to our respective infection prevention departments so that they can call and ask questions if they need to. We also have a button. We call it a button. It's a HTML. It's built under HTML, but it'll take them to the order page where they can place whatever orders they need to. I mentioned FHIR previously. We do want to look at using some of the reusable applications and reusable technologies such as Smart or Connect, and there's a multitude of others, and we do want to incorporate these. We just have yet to figure out exactly how we're going to do that based on our customization that we have locally. And with that, I'll turn it back over to Dr. Steph Helscher, and she can finish us out.
Thanks, Dwayne. Yeah, so to conclude our Texas team's part of the discussion today, I would really like to close with some observations regarding current state gaps that are still there. This is really why we partner with agencies like HHS and CDC. We look to them for guidance and guidelines to supplement the expertise of our infectious disease local experts and to provide them back with evidence-based best practices that are working or not working in real-world situations. This comes in real handy when translating these guidelines, and the main reasons why our partnerships really do need to continue. Coronavirus guidelines, thankfully, as Dwayne said, are fairly stable. They're not like Zika, where it feels like they're changing every week or two and you really have to pay attention to them. We don't anticipate too many more changes before it's finalized, Zika was very dynamic and introduced crazy complexities into its algorithms, like Dwayne said, like sexual partner travel and everything else that came along with it, pregnancy. The manual aspect of these digitalizing these guidelines is still what makes infectious disease CDS difficult and time consuming to maintain. And to keep it safe and evidence-based, it's ever changing on a daily basis. So you really do have to have some dedication. And the more we can automate this, or Smart on Fire, Connect, anything, we look forward to continuing a partnership with that, because that really, it's the next step. And I think a lot of facilities nationwide are looking for that. The next, CDC has started shipping test kits. I think they started on the 6th. But not all are going to go to areas that will be of a timely benefit. There's really only a limited amount they were able to distribute, so not everybody's going to get one. And so with testing orders, still potentially they could change in the future. We may or may not wind up getting our own test kits in the future, so there's a little hesitation to automate that process other than send out orders in the system. So we're kind of in hover mode about that. But hopefully the CDS will be solidified pretty soon, but there's still going to be some gaps in that with the ordering process. It's kind of in limbo still. And finally, there's a lot of discussion about automation of infectious disease clinical decision support, like orders, referrals, and Dwayne talked about that a little bit. And with most of this, I agree with. I think automation, the more you can automate, that's fantastic. But you kind of have to ask yourself, just because you can doesn't mean you should. It's important that as you develop your own processes in your own regions and locations, to talk to your experts, talk to your infectious disease departments, your clinicians that will be using it, your vendors as to what they have in their capabilities. Our issue with the lightning bolt hit when we had the Zika algorithm development. We decided to kind of look back and see what the Ebola build had looked like. And we did notice it had an automated cart, isolation cart order, that every time that alert fired, and it was not very tight, I believe it was for if you were anywhere in the continent of Africa and Western Europe for a very long time, even though Western Europe was turned off very quickly with the guidelines. Every time it fired, they sent a full isolation cart up to the patient's room, no question asked, because it was automated. It said, oh, Ebola is very bad. We want a cart up there immediately. I don't know who made that decision initially. I'm sure there was a discussion on it, and it was a good decision at the time. But because it went on and on for so many years, we, knock on wood, never have had an Ebola case in our region. And so that's a lot of money that just gets kind of thrown out the window. Thankfully, we don't think the patients directly get charged for it, but to restock a cart or re-sanitize it, that's all cost. And so they were getting one every time an alert fired. So that's really something that should be considered with your automated one. And that's just our perspective on it. Of course, you got to do whatever's best for your process and your workflow and your location. And essentially, that's all I have for today. Next slide, please. I think we get to wrap it up and take some questions. Jim, back to you guys.
Great, thanks. Dan and Rachel, if you guys are okay, I'll just go ahead and read some of the questions that have come through.
Sure, go ahead.
So the first question we have, we might need some clarification on. Dan, I think you may have been working on it. Will the results of the ONC web survey about COVID-19 experiences be synthesized and released at some point?
Sure. Andrew, you may have misunderstood, or I may have misspoken. There was not an actual survey done by ONC. We just convened a discussion with EHR developers. I can synthesize that discussion. It was essentially similar to what you saw today, in that vendors had taken the guidance that existed to date, that had been published by CDC, and had done some sort of basic decision support to guide providers in diagnosis and testing. If you have a follow-up question, Michael Favreau, you can type that in, and I will follow up.
Sorry, yeah, that was actually Andrew. I'll go on. So we've got this question a few different times. Are there plans for COVID-19 or future emergencies to build FHIR-based resources that would return clinical decision support. We've got that from Michael in the Q&A and John Lee in the chat as well. So, Dan, do you want to start that or do you want me to?
You can go ahead.
Okay. So one of the things that I think we're looking at is from a bigger picture, how are we better prepared to respond to these types of events and make the clinical decision support more operational, more interoperable? I think we got some other questions about what the delivery mechanism was for the algorithms that we developed if we use CDS hooks. So really what we did with Zika and Ebola was to produce those paper-based algorithms and distribute those via these webinars and the ONC and CDC websites. And we really didn't take it yet to that next step of making something that was consumable. So I think that is definitely something that we would like input from this community on, is what are the best mechanisms to make that type of guidance available in a more consumable format so that everyone doesn't have to go off and build this on their own. Dan or Rachel, did you want to add anything to that?
No, I think that sums it up.
So we have another question from Pamela, wondering how long it takes for the value sets of informatics terminology to get updated. Loink and SNOMED CT both released terms near the end of January, but I didn't see it listed in Dan's slides.
So to that question, I believe that those code sets are draft releases, and the value sets that we posted and the information we posted was all publicly available information on COVID-19 from CDC. So there was no draft information there. And I don't think there is any like standard how long it takes for value sets to get updated. That can vary a lot for a variety of reasons. But we are constantly thinking about how can we make it quicker.
So we have another question. Dan, you mentioned that changing guidelines affected the Zika efforts. What strategies were used to address that, and to what extent was it addressable?
It was extremely difficult because the speed at which they were changing and coming out, and we could readapt the guidelines using our processes. There would be another change in the queue right behind us. So it was extremely difficult. There are efforts underway at CDC in developing clinical decision support in a timely manner. And our efforts here in this space again today are a matter of biology has caught up with us again before we have streamlined processes to handle getting the guidance out, and in particular, getting out the guidance in any way that's consumable by electronic health records. So I think that probably about covers it. David asks, Atribin, how many EHRs hospitals have these alerting algorithms operational for COVID-19? I don't know how many hospitals. I know that we spoke with 8 to 10 EHR vendors who all had something similar underway, if not implemented. But I couldn't tell you how that translates to number of hospitals or lives in the US. So we did have all the major vendors on the call, and they were all working on or having had released something to that to meet that need.
Great, thanks, Dan. We have a couple of questions now about sending and receiving information between public health and the hospitals for lab orders, lab tests, and other types of information that might need to flow back between the provider and public health. Dan, did you want to take that, or?
I'm sorry, I was reading all of the questions. Which one were you asking about, Jim? I was reading ahead.
Sure. How can public health be better prepared to send and receive electronic messages from hospitals? So things like lab reports, case reports, and then public health getting back information to the provider.
Well, I think the lab report example is well defined in the electronic lab reporting that has been in meaningful use since meaningful use 1. If anyone wants to report out on either positive or negative results from implementing the lab reporting to public health, that they'd be appreciated. You can do that offline, and that would be much appreciated. And with electronic case reporting, there is a large effort underway, and that is with a project called Digital Bridge on electronic case reporting, and have had some very successful pilots. And so, I mean, I would expect electronic lab reporting, or excuse me, electronic case reporting to be something that's available in the near future. And there is not only the HL7v3 version, but there is also work underway with FHIR for reporting. So.
Jim, this is Susan McBride, and from the reducing provider burden, I'd like to respond to that from a clinical standpoint. And I think one of the things that's really critical about this is that we collaborate with one another, and that public health, you know, or any other federal agency for that matter, would attempt to create solutions without providers at the table. And I think a really good example of some of that effort has been these types of initiatives where we're on, you know, webinars together discussing what we need and how it rolls out, how it impacts the clinical field. But more importantly, invited type initiatives such as the CDC's Kaizen that they had, where they made sure to get the field representation from, you know, great cross-section, as well as IT vendors, IT developers. So that's the way we're going to create solutions that really work effectively for us, because we think about impact from all angles. And that's our success story, I think, in many of these types of initiatives.
Great, thank you, Dr. McBride. I'm going to skip around a little bit, Dan, because I think some of the questions are things that we've addressed. I'm going to try to get to some of these newer ones. Seth Foldy asked, the countries of travel concern are likely to change over time. Is there a way EHRs could access machine-readable list of countries that trigger concern rather than needing human coding updates? Do you want to say a little bit about what we did for Zika with that, Dan?
Sure. So we published the information about what data sets were in use. Those were all available in FinVads or other locations. So we published the OIDs where someone could, the object identifiers, where someone could hit those online and consume them. We published them, the initial set, as written documents, just so folks could update their systems and know where to point. As far as ongoing, how they manage that, or how any vendor or installation manage that, that would be up to them.
Great. We have a question from Catherine Stays that I think is probably for Steph or Susan. I really enjoyed this talk and bringing in the nursing informatics perspective. So often CDS is directed towards physicians because it concerns the diagnostic activities rather than the management activities. Do you have any input on the CDS needs of nurses in this context? And should the CDS be directed to the nursing role rather than the physician role?
This is Steph, and
oh, yeah, great, thanks.
Yeah, I can take a first crack at that. I'm sure Dwayne and Susan will probably have something as well. Yes, it's tough sometimes being in the nursing aspect of it. A lot of things are provider or physician driven, the big concentrations on documentation burden, as it should be. But a lot of stuff is also nursing burden as well. And it's just a work in process that everybody's trying to work on and make better. But we did make sure that the nursing, boots on the ground nurses, the ones that are doing this every day, are integrated into the process and have a say-so in it. And actually, this is a side comment, but I have a publication coming out with Susan a little bit where we went back and we turned this on and then did a study as to clinician satisfaction. And strangely enough, you know, we had some pretty good results with the nurses and their feedback in the whole process. So it's vitally important to keep them involved as well. Now, Dwayne might be able to speak a little bit. We do have 2 different types of alerts in the systems right now. We are providing the info buttons and such to the providers, but there is one for infectious diseases going to the nursing and the other clinical staff as well, like speech and physical therapy and such, to let them know, hey, this is a potential TB patient, or this is potential measles or coronavirus. The more vector-borne diseases like Zika and yellow fever or stuff that we have alerts for, we try not to burden the boots on the ground, the nursing staff with, because, you know, yes, they need to know about it, but it's not, you know, unless you've got a female Aedes aegypti mosquito running around and it bites you and then bites them and everything else, you're probably not going to get yellow fever in that room. So we do try to weigh, you know, how much do we want to burden people with alert and alert fatigue, possible contributions, and pick and choose. And we ask them, you know, do you want a yellow fever alert? No, we don't. Okay. But the providers, yes. So we make sure that we turn it on for them, but not necessarily for the nurses. But they are already integrated in. They're the first people in the room. They need to know that you've got a possible bad juju going on here with the disease process, and they're the ones that are going to be turning on, hey, we need a cart. Hey, we need to put them in a reverse isolation room. Hey, we need to do this, this, and that. So excellent question. Susan or Dwayne, did you guys have anything to add?
I just have
Dwayne.
one thing. Oh, go ahead, Dwayne.
Oh, I was just going to add to what Steph said. We are actually in the process of putting out the alert that we're providing for the providers to the nursing staff or everybody else also. Basically, here at UMC or at Texas Tech and UMC, we allow our nurses to place verbal orders. I know there's some EHRs or some facilities that don't allow nurses to place orders with the electronic health record, but we do here. And so we've been kicking around for about 2 weeks now of just doing away with a less functional alert that goes to the nursing staff or the non-provider staff, I guess is the way to say it. We also try to refer, when we're talking about our ID alerts, we also try to refer to clinicians, and we try not to segregate providers and non-providers. I know that's not possible all the time, but that's just something we do here. So going forward, hopefully we'll get this up and running in about a month or 2 or so, and we're going to allow or provide the URLs for the alerts so the nurses can have that ability to go look at it also. So I'm done, Susan.
So yeah, just real quickly, I think what both Steph and Dwayne pointed to is the importance of taking everything that they're giving us in terms of these technical algorithms, whether they be from the CDC standpoint or HHS and ONC's recommendations about how to technically translate, map it to your workflow. And so for ours, you note that our workflows had nursing assessment, but then where do you go from there? Because nurses are not the only clinicians that need to get triggered in order to do the right thing at the right time for the right patients. So that's why it's so critical that we share these types of workflows that are modifiable. And I noted that someone's looking for our our email address again, and I suspect that's why, because that's exactly what we did with Ebola and Zika. We took all the information, we translated it to clinical workflow, and then we started sharing those clinical workflows, and you can take those and modify them for your own purposes. But I think one of the important things that's being noted here is, where is it getting triggered and who should be triggered depending on what you're dealing with and your clinical workflow. And then Dwayne, of course, pointed to our own order processing and why it's so relevant for the nurses to be involved in this process. So that we've got some amazing nursing informaticists on our team, in case you didn't already note that.
Great, thank you for those excellent answers. I think we have time for a couple more questions. Dr. Karras has mentioned that we've talked about limited test kits. Can we discuss how CDS could aid in prioritization of what samples get sent to public health labs for definitive rule-out testing? And I think, Dr. Karras, what we would do there is really, from our lessons learned with Zika, look at what those the guidance documents are and turn those guidance documents into a type of algorithm that, as Dan says, has definitive questions, definitive processes that then people could actually put into their products to help with that. I think that would probably be the kind of activity that we would do as that guidance started to come out, if that were something that people started asking for. Dan, did you want to add anything else to that?
No, that's a point was made, and that was exactly with Zika the sorts of considerations we were looking at in getting algorithms out quickly, because with Zika, with limited test kits, there certainly were lots of people who wanted to be tested who there was just no need to test them. And it's very important that, especially in a situation where there aren't enough resources, that clinical decision support can be used to help aid the use of resources.
Yeah, and as a follow-up, Dr. Karras has pointed out that that guidance may be unique state by state as travel becomes less as a factor. And yeah, that's certainly true. And that was true during Zika as well.
Yep.
We have an interesting question from David Attribune. Are these EHR enhancements for COVID-19 something hospitals or providers will have to purchase? Will they involve rollout of a new product or a change to their existing EHR? So I'm going to actually pose that question back to the community. How, we obviously don't have any, we don't regulate or govern anything about how, your relationship with your EHR, but are there things that can help make this easier, from the standpoint of the providers and the clinicians? Are there things that we could help do to make the rollout of this easier and more seamless with the products that you use?
So this is Dwayne. Can I make a comment on that?
Yeah, thanks, Dwayne.
So while we're a very customized shop, I know there is generally, sometimes there's cost related to taking upgrades and things like this. But what we did is we had, prior to us starting our doctoral journey, we had like an infectious disease form that was kind of clunky to use. And so internally, we reevaluated that. And I believe Dr. McBride and Dr. Helsher has mentioned that before, but we looked at our local process to see what we could do in order to make it better. And so just based on that, we re-engineered or reconfigured the intake form to allow for it to flow a little bit easier. And anyway, I think that helped with some of the burden. That's why we got better scores as far as satisfaction scores. I think I answered that, or helped answer that anyway.
And this is Stefan, to add on top of what Dwayne said, it might answer the question a bit too. It depends on your relationship with if you have an informatics team within your institution that can actually make modifications to your particular EHR, and what their agreement is with your vendor. There are vendors that are much more tight on what can be done within the EHR, and some that are a little looser with what can be done with qualified personnel. So it's best to talk to your informatics team, assumedly you have one, but somebody who represents the liaison between you and your vendor, and they can tell you what packages might be available for the vendor. Typically, I don't think they charge extra for these kind of things. I think it's kind of encompassed in your agreement with your vendor, but that's another question for your on-site team to see. They might be doing something custom that would just be encompassed within their job role, or your vendor might be offering a package. And a lot of the big players have already turned out packages. So that would be a good question for your guys there.
We have a couple of questions. Thank you. We have a couple of questions in regard to the scope of what we're doing here. And Priyanka Suryo and Faisal Riza. Priyanka asks about monitoring and surveillance outside of the electronic health record. Right now, the scope of our discussions here are electronic health records and working with the electronic health record community. Have not reached out to the syndromic surveillance community, but there are standing calls where I'm imagining those discussions will take place. Likewise, Faisal Riza asked about preparedness posture and looking at potential outbreak epicenters such as mass gatherings such as the Hajj in terms of prevention and control. Right now we are focused on the US and electronic health records, which is the scope of the primary scope of the work that ONC does. Any other questions? We have 3 minutes to go.
Dan, this is Dwayne. I just to add to what you were talking about with the gatherings and the groups, we didn't identify locations per se or discrete data on that, but we did put in a label on the intake form. We have an option to say it says areas of high risk, and we can put a label in there telling them what to watch for. And so that's kind of how we address that. I know this is kind of outside the scope of what we're talking about today, but just that's one thing we found during our investigation of how to make this better.
Yes, and if Faisal wants to email us directly, we can tell Faisal what we did about the Hajj in our build, if you're curious.
Absolutely.
Thank you.
So we're at 2 minutes to go. This is Dan Chaput from ONC. We'd like to thank you for your participation, and we would like to thank our partners in the electronic health record vendor community for participating and sharing information. And all of the information that we presented is available publicly on the CDC website. And Rachel, is there anything else, or Jim?
Just that we also want to make sure to thank our 290 attendees total for today's webinar. Thank you all so much for your active participation.
Thank you, everyone.